मैंने पहले व्हाट्सएप से अपने आप को ईमेल किया और फिर वो कई सारी चीजें मांगने लगा। पहले मीटिंग
Thank you,
आईडी
sir, for joining. And
सब।
now it's time to
हाँ।
start. So, good morning, dear friends, respected faculty, and dear delegates. It's Sunday morning, nice Sunday morning in Delhi. So, we welcome you once again. I request Dr. Mukesh Dhankar, Secretary IP Delhi, to start the proceedings.
Sir, good morning. It's my utmost pleasure to invite, welcome you all for this another webinar on eNeonatology. So I welcome Dr. Satish Aggarwal, sir, who is the speaker for this session. Dr. Jitendra Gawane, Star World of Indian IAP. Dr. Alok Bhandari, sir, who is the president of Delhi IAP, also the president of Delhi Medical Association, and Dr. Ajay, who is hosting us. Welcome all. Over to Ajay, sir.
Thank you, Dr. Mukesh. I request Dr. Alok Bhandari, sir, to say a few words.
Well, good morning, friends, and good morning, Satish ji and Dr. Jitendra Gawane, our chairperson for today's session. Jitendra ji is a professor of pediatrics and is PICO in charge at MGM Medical College, Navi Mumbai, and he is an executive board member of CIAP of last year also and the current year also. It is not the executive board member only, he is the dynamic EB member and the heart and soul behind Mumbai and Navi Mumbai pediatrics. I will not be wrong in saying that our central office also rotates around Jitu's activities. He is very staying closer to the office and always available for IAP work. I have seen him working very hard, diligently for last almost a decade. And we are really happy to have Jitu here on this session of neonatal surgical conditions by Dr. Satish Aggarwal, sir. Ajay, आप sir को introduce Dr. Jitu करेंगे. I'll request Jitu to say a few.
Yes, sir. Good morning, Delhi IIP. Respected Alok Bhandari, sir, Gupta, sir, Dinkar, sir, Agarwal, sir, and all respected senior members of Delhi IIP and my friends. It is my privilege to welcome you to this important eNeo series, which is taken by the Delhi IIP. And one of the important session in neonatology is always a surgical neonate. The field of surgical neonatology has been made tremendous progress in recent years. It is crucial that we should know the best practices and best technologies, what has progressed over last few years to improve our outcome of these vulnerable patients. Neonatal surgery, of course, requires unique blend of technical skills, critical thinking, and compassionate care. And none other than Dr. Satish Aggarwal, sir, will who is a neonatal surgeon at Gangaram Hospital, will highlight the important issues in surgical important issues in neonates. That brings in the latest advantages, challenges, and controversies in surgical neonatology. I thanks Delhi IIP for inviting me and sharing my views on Delhi IIP platform, and I wish all the best for today's session. Thank you, sir.
Thank you, Dr. Jitendra. Now I request Dr. Satish Aggarwal, sir, to please start his presentation. Sir, please make it full screen.
Right. So, yeah, and play. So, are you seeing my screen?
Yes, sir. Yes, please.
Right. Okay. So, thank you, Dr. Jitendra. Thank you, Ajay. Thank you, Dr. Mukesh. And thank you, IAP Delhi. And thank you, Pankaj. Pankaj has not been able to join. He is traveling. It's my privilege to be a part of this forum. And I work at Sir Gangaram Hospital. I'm a pediatric surgeon and a neonatal surgeon, not an exclusive neonatal surgeon. I do a lot of pediatric urology, neonatal surgery, thoracic surgery, intestinal surgery, and all neonatal surgery. So the topic given to me was surgical newborn. Now, as all of you know, surgery in the newborn can be needed for a variety of conditions, but I have chosen neonatal intestinal obstruction for today because this in itself is a very vast topic, and it is one area where I feel our neonatal residents should be exposed to so that they don't miss the diagnosis and they refer the patient early. It is my personal experience that neonatal gut issues sometimes get overlooked, and sometimes it is relatively late before they are referred. I'm making this as a very, very mild statement, not pointed to anybody. Most of our neonatology units are very quick to pick it up. Sorry. And refer early, at least in Gangaram, I have seen, and in many other neonatal units where the children are referred from, they make very prompt diagnosis and refer the patient. As you know, the neonatal surgery can be needed for things like thoracic surgery, like tracheoesophageal fistula, esophageal atresia, congenital diaphragmatic hernia, congenital lung lesions, sequestrations, lobar emphysema, and CAMs, cystadenomatous malformations, when the child is symptomatic at birth. And then a wide section of neonatology, neonatal surgery, will be related to pediatric urology, the antenatally diagnosed hydronephrosis, unilateral, bilateral, with hydroureters, with distended bladder, with valve bladder sign, with keyhole sign in the bladder, like typical posterior urethral valves, oliguria, and other combinations. So these are individual cases. I will not be telling them in details, but my focus will be on neonatal intestinal obstruction today. But I would like to make it very interactive. So at any time when the panelists feel that I need to be interrupted, I need to address some specific issues, I'll welcome your comments and your inputs.
Thank you, sir. So we have question answer box. We'll keep on.
Yeah, at any time, feel free to interrupt because I want to make it very interactive. This is a learning, session, and everybody must learn from it.
Okay, sir. Thank you.
Right. So I'll be covering this topic under these headings. Now, this is a broad incidence of all conditions of neonatal gut combined, not a generalized. Now, the common causes. If the resident and neonatologist remembers these 7, important causes, it covers more than 90% of the spectrum. So, top 2 are the atresias, duodenal atresia and jejino-ileal atresias, and then malrotation with volvulus of the midgut, Hirschsprung disease when presents neonatally, meconium disease with its spectrum, and necrotizing enterocolitis, which everybody has seen. So there are certain pointers in NEC which point towards a surgical intervention need. And then anorectal malformation, and it's a topic in itself, not very commonly dealt with within the ambit of neonatal intestinal obstruction. If time permits, I'll delve into that also. So let's start with prenatal diagnosis. If antenatal ultrasound tells polyhydramnios, dilated bowel loops, echogenic bowel, or calcification, or dilated proximal esophagus, or bowel in the chest. So these are the 6 features on antenatal ultrasound which should point towards a bowel problem. Bowel in chest is diaphragmatic hernia, dilated proximal esophagus is esophageal atresia, calcification is meconium peritonitis, and dilated and echogenic bowel means either atresia or meconium disease or something wrong with the bowel. And when you have a bowel problem in prenatal diagnosis, then one must consider what next. If the prenatal diagnosis has been made fairly early, then as we know that duodenal atresia is a common cause. 50% of them have polyhydramnios. And if therefore dilated bowel with polyhydramnios is there, then it is an indication to exclude trisomy 21 by amniocentesis or other tests. So a genetic reference must be given at that stage of pregnancy to exclude certain things and to prognosticate to the family. And when you have this scenario, then the mother should be referred to an institution for a conclusive prenatal diagnosis and institutional delivery. So how does neonatal obstruction present? I've highlighted it in green because green is surgical. Green is the green signal for the surgeon. So whenever you see bile-stained aspirate, which is green, not yellow, green aspirate is almost always surgical. And if any neonatologist at any stage in the NICU sees anybody having bilious aspirate from the nasogastric tube, must call a surgeon for a look at the child. The next is abdominal distension and then failure to pass meconium. Now, presentation is often similar with many conditions. Say, for example, distension will be there in jejunal atresia also and in ileal atresia also, and both will have bilious vomiting. But the degree of distension and timing of distension is important. Degree and timing of distension is important. And then when it comes to passing meconium, one must remember that 95% of babies who are term-born will pass meconium, the first meconium, within the 24 hours, the first 24 hours. And the preterm babies will pass meconium within the first 48 hours. Now, when we talk of distension, look at this baby. So in the picture on the top, you can see there are visible loops in a step ladder pattern. One loop is there, the other loop is there. It's not a football-like distension of the abdomen. And the bottom picture shows the surgical finding. So this is the bowel atresia. This is the distal, which is quite small gut. This is the defect in the mesentery, and this is the proximal dilated segment of the bowel. And this was a proximal bowel atresia or jejunal atresia. And you notice the distension is limited to the upper abdomen, few visible loops. And this is the dilated jejunum. Okay. So distension and duodenal atresia may not be there. Distension and jejunal atresia is somewhat there. And then ileal atresia, it will be even more. Look at this condition. This child also has distended abdomen. So compare this distension with this distension. So here there are more loops, and the level of obstruction is at the ileocecal junction. So this is the collapsed colon, and this is the cecum, and this is the ileocecal junction. And the distension starts somewhere here, which is the terminal ileum. Another child. So you see a lot of dilated bowel loops, but no gas there in the pelvis. So this child has developed distension within 48 hours of birth, and then has presented with distension, bilious vomiting, and this is the X-ray. So this suggests a distal ileal atresia. Now, these are the situations where the child is not born with distension at birth, the atresias. Because for atresias, for the gut to distend, the child needs to ingest air. And it takes time for the child to ingest air. So the distension will not be there right at the time of birth. It will appear within first 24 hours, say in the case of jejunal atresia, and 48 to 72 hours in ileal atresia, and things like that. It may not be there at all in duodenal atresia at the time of birth. But as soon as the child starts crying, the stomach and the proximal duodenum will become filled up, and then upper abdominal distension will occur. But there are certain conditions where the child is born with distension. So this is a very, very subtle subset of neonatal patients who will present with abdominal distension at the time of birth. So what is the differential diagnosis of distended abdomen at the time of birth? So these are the only conditions which will present with distension at the time of birth. Cysts, any form of cyst, it may be a duplication cyst, it may be a lymphatic cyst, it may be an omental cyst, lymphangioma, retroperitoneal lymphangioma. And then retroperitoneal soft tissue mass, such as a teratoma. Retroperitomas are not so uncommon. And then the gut condition which will present as distended abdomen at birth, a large chunk is meconium peritonitis. What happens is there is antenatal perforation of bowel. So the meconium comes out of the bowel, it irritates the peritoneum, leads to a pseudocyst of the meconium and leads to calcification. And the child is born with quite a massively distended abdomen. If the antenatal diagnosis is there, echogenic bowel, and if there is calcification, if there is polyhydramnios, then the diagnosis is almost certain that this child has meconium peritonitis. Sometimes the cysts are very giant, and we call them giant cystic meconium peritonitis. The next condition is pouch colon syndrome. Pouch colon syndrome is a very specific entity, very prevalent in the northern India. And this entity was described from North India only, from Lucknow and PGI Chandigarh many decades ago. There are 4 types. So whenever there is a pouch-like dilatation of the distalmost bowel, it leads to distended abdomen at the time of birth, and it is often associated with anorectal malformation. So if there is distension at the time of birth and there is no anal orifice, take it, and if it's a male child, then it is a pouch colon syndrome. If it's a female child, then it could be cloaca, it could be hydrometrocolpos, it could be pouch colon, anything. So, and then the last one is hydrocolpos. Hydrocolpos is distended vagina. In cases of cloacal malformation or in cases of vaginal atresia, then the lower abdomen is distended in a female child. So if it's a female child, distended at birth, with no anal orifice, suspect hydrocolpos pouch colon syndrome. But from the gut point of view, distension at birth means meconium disease of infancy, usually complicated, may not be complicated, as we will discuss a little later. Now, this is the example of a neonatal mass. Now, neonatal Wilms tumor, but it presents with localized distension at the time of birth. Now let us come to radiology. Radiology is very important because many a time we get patients who have already gone through a CT scan for a neonatal obstruction, which is completely not justifiable. Through this forum, I want to convey to everyone that plain abdominal X-ray in 2 planes is the most important investigation and at times the only investigation required. So plain X-ray abdomen is the investigation to diagnose neonatal intestinal obstruction and to make decisions also based on this. We do not need ultrasounds, we do not need CT scans, MRI scans, and we do not need many dye studies. So plain abdominal, just remember, what is the choice investigation in neonatal intestinal obstruction? Plain X-ray abdomen. Then I have listed contrast enema and contrast upper GI. And I'll delve into it a little bit more detail. When to order contrast enema, how does it contribute in decision making? When to order an upper GI contrast study and how does it contribute in decision making? But again, I'll come back that plain X-ray abdomen is the most important and sometimes the only investigation required. And when I talk about contrast, contrast means gastrography. Please take away the barium from your list of contrasts as far as neonatal gut radiology is concerned. Contrast means gastrographin and nothing else. You could also do it with iohexol, the water-soluble non-ionic contrast, but they are extremely expensive and most of the time not needed at all. So gastrographin, gastrographin, gastrographin. So few examples. So this is typical duodenal atresia, which presents as double bubble sign. So this is a plain X-ray abdomen in erect position. This is the stomach bubble, and this is the D1, duodenal 1. It is associated with Down syndrome in 30% of cases and cardiac anomalies in another 30% of cases. The onset is within few hours. The child will be born absolutely fine at the time of birth, no distension. They will even be fed, but after feeding, they will vomit bile, and they will develop upper abdominal distension. When you pass in a nasogastric tube, aspirate, the distension will disappear. Now, sometimes duodenal atresia can have non-bilious aspirate also, and that happens in 20% of cases where the level of obstruction is before the ampulla of water. So preampullary duodenal atresia will present as non-bilious vomiting, but will still have a double bubble sign. Post-ampullary duodenal atresia will present as bilious vomiting, distension soon after birth, which will settle down on nasogastric aspiration. And when you have a child born with duodenal atresia, always ask for an echocardiogram and always ask for a genetic opinion. Examine the baby for features of Down syndrome and then proceed to surgery. Surgery in duodenal atresia is not an emergency. It's not that you have to operate on day one itself. You can take 2 days, 3 days, keep the child on nasogastric suction, nothing will happen. Start on PN and work up the child. Let the fetal circulation transit into adult type of circulation. Do the cardiology workup, do the genetic workup, discuss with family, and then take a call and do a duoden or duodenostomy. Treatment is very straightforward. Surgical treatment is pretty straightforward. But important thing is post-surgery, these children take a lot of time to accept feeds because duodenum loses its motility quite a lot depending on the degree of dilatation. And this dilatation takes time to resolve. And therefore, it may take 1 week, it may take 2 weeks even before the child can be started on feeds. So this is another X-ray, which is a supine X-ray showing duodenal atresia. So distended stomach reaching almost up to the pelvis. If you put in a nasogastric tube, you can deflate it. So the same X-ray, supine and erect. Jejunal atresia, the onset will be slightly later than the duodenal atresia. The child is otherwise well. The child has variable distension. They generally are not associated with cardiac defects and trisomy. And treatment is also fairly simple. What we do is we resect this terminally dilated portion. So cut it here and join this with this portion, which is distal. This should be excised because this will not perform its myoelectrical function so well. So therefore, the segment of bowel immediately proximal to the atresia is generally resected for its lack of myoelectrical properties. And then we do an end-to-back, end-to-end anastomosis. So this is ileal atresia, more gas. But you see, there's no gas in the pelvis. One more feature here is that the neonatal plain X-ray, the limitation is you cannot distinguish whether a given loop is small bowel loop or large bowel loop. Say, for example, in this X-ray, the loops that you see in the center are small bowel loops. This is a fairly obvious thing. So the large bowel loops are generally situated at the periphery. No, so these loops, we do not know whether these are colonic loops or small bowel loops. Very experienced physician, very experienced surgeon can make a calculated guess depending on the clinical features of the child, whether these could be a large bowel loop or small bowel loop. But most of the times, the resident should comment that it is not possible on a plain X-ray abdomen to distinguish small bowel loops from large bowel loops. As a generalization, centrally located loops are small bowel loops. Peripherally located loops can be large bowel also. Now, this is an X-ray of a child who was born with abdominal distension at the time of birth. So if you look at this X-ray, this child is distended at the time of birth. But if you look at the X-ray, the loops are not that greatly dilated and there is some haziness some few flakes of air here. And this segment shows some soap bubbling. This is called soap bubbling, as if air has mixed with meconium with proximal dilatation. Compare this with this. So these loops are more dilated, but almost all are gas filled. There is no haziness. There is no soap bubbling. And this child developed distension 48 hours later. Compared to this child is born with distension. X-ray shows some haziness, especially in the right side. So this is typical of meconium disease of infancy, which is uncomplicated. This typical soap bubbling is because of mixing of air with thick meconium in the right side. So this points to meconium disease of infancy. Now, as I mentioned, so there are some peripherally located loops, some loops there. This may be stomach, some loops there. So how do you know whether this is a small bowel loop, all these loops are small bowel loops or large bowel loops? And there comes the importance of a dye study. Now, the next question is, okay, which dye study? So how do you decide which dye study to order? In this child, I wanted a dye study. In this child, I did not want a dye study. The diagnosis was fairly certain in my mind because of the clinical course of the child. No distension at the time of birth, onset of bilious aspirate, then gradual distension, and all these dilated small bowel loops. I did not want a dye study. On this child, I wanted a dye study because the child was distended at the time of birth. There is some soap bubbling. The dilatation is not that much. I'm not sure what we're dealing with. This could be a meconium disease of infancy. And we know that meconium ileus or meconium disease of infancy, which is uncomplicated, can be treated by medical means, can be treated by contrast enemas. Therefore, I ordered a contrast enema. Why not a upper GI series? See, we have an X-ray. It shows bowel obstruction. Choice is with us whether we do an upper GI series or a contrast enema, lower GI. The reason is pretty simple, that the lot of air in the intestines, lot of air is in the intestines. Where has this air come from? Obviously, this air has been ingested by the child and it has filled up so many loops. So if you put in a dye through the stomach, the dye will also have to travel the same course as the air has. So you don't get any additional information. The dye will fill up these loops only, which are filled with air. What you want the information about is the bowel loops which have not been filled by air. And that you fill by contrast, which is gastrographin. So this is the gastrographin study in this same child. So you see the colon is quite small in caliber compared to the ileum. And if you look at these filling defects, it is filled with pellet-like meconium. So this is typical of meconium disease. This is called microcolon. Microcolon is defined as a diameter of colon less than 1 centimeter on contrast study. So we clearly know after doing this contrast enema that the dilated loops were not colonic loops. They are small bowel loops, and we have visualized the large bowel loop by putting in dye through it. So if there is a lot of gas on the plain X-ray, and if you want a dye study, it should be a contrast enema. If there is too little of gas in the plain X-ray, then you know that you have to do an upper GI contrast because you want only those segments of bowel to be filled, the upper bowel loops to be filled to know what is happening. Is the dye going distally or not? If in that situation you were to put dye through the rectum, then it will it will cover the entire course of colon, then it will enter the ileum, then fill the ileum retrograde. So what's the fun? If the air has not been able to be passed beyond certain limit, upper abdominal distension, you want a dye study, then it should be an upper GI study. So this is typical meconium disease. So there's the terminal ileum which is collapsed, and proximal ileal loops are filled with this thick sticky meconium. So this is the thick, sticky meconium cast if you try to express it by doing an enterotomy. Now, what is this? So this is distended loops and calcification. This child again was presented, he presented as distended abdomen at birth. And this is meconium peritonitis. So if you see the calcification, distension, proximal dilated loops, that means this bowel has perforated antenatally, and after perforation, it has resulted in an atresia, which leads to proximal dilatation. If you do a contrast enema in this situation, you will find this microcolon again, rectum, microcolon. So you know that all these loops are small bowel loops. Even this loop is small bowel. This is not colonic loop, even though it is in peripheral location. Calcification is the clue. Distension at birth, plain X-ray showing calcification, antenatal perforation, meconium peritonitis. Distended at birth, no calcification, meconium disease could be uncomplicated. And when you have suspicion of meconium peritonitis, meconium disease of infancy, you have to rule out cystic fibrosis. But there are several tests, you know it better. We used to do sweat chloride in olden days. Now you have genetic testing and specific proteins to detect a possibility of cystic fibrosis. Now, bowel obstruction in preterm neonates poses a very, very specific challenge. It's very difficult sometimes to differentiate between true surgical bowel obstruction versus prematurity-related dysmotility of gut in a preterm child. So it's a challenge. Now, this is a typical example where we've demonstrated that sometimes segmental dilatation of small bowel in a very preterm baby could be a precursor to in utero perforation. So if this child was born at about 30 weeks or 28 weeks of gestation. So if this child was not born so preterm, he would probably have been born with a perforation, antenatal perforation. How? I'll show you. So there's the child, he's quite distended. And there's the X-ray. There's the X-ray on day 4 and there's the X-ray on day 5. The child has not been fed. Now you see there's no feature of pneumatosis, but you see this blob of air here on this side, which is persisting on day 5. It is not free air because it is very, very, very well defined. It's not all over. There's no NEC. So what is it? Clearly, this is something surgical. Even though there are many proximal loops dilated, we knew just by looking at this X-ray. So few X-rays are surgical. Sometimes I go to the nursery and there are few X-rays on the view box and I'm looking at some other patient, but I look at the view box and I see some X-ray like this. I immediately point out, oh, this is a surgical. Where is the baby? And believe me, we have picked up certain surgical conditions like this. So this is clearly surgical. And when we operated on this child, you can see that this bowel is quite dilated, almost about to perforate, quite tense. And when we resected this segment, we were able to join the two ends end to end, and this child became fine. Similarly, this is another child, a preterm, on day 3, upper abdominal distension and bilious aspirates. You can see this upper abdominal distension. And look at this X-ray. What does it show? It shows few mildly dilated loops here, but look at this blob of air, and look at this. What is this? This line which is here towards the midline, and as we go up, it goes to the right. And this is a supine film. So this is a free gas. And this segment that you're seeing, this white line that you're seeing, is actually the ligamentum teres, the free margin of the falciform ligament, which runs from the umbilicus as the left umbilical vein to the liver. and there is air on both sides of the falciform ligament. So this is free gas in the abdomen, but there is no pneumatosis. And when we explore, we find this perforation. See this bile stained fluid as we open the abdomen, and this is the condition of the bowel, and here is the perforation. And again, there is a segment of dilatation. So in this child, what we have done is, we call it a Bishop-Koop anastomosis. So this is the segment that we have resected. And this is the proximal segment, which we have anastomosed to the distal segment. And the distal segment has come out as a stoma, like a chimney stoma. Now, this child's condition of the gut was not so good as to qualify for a primary anastomosis. So when the condition of the gut is good, like in this child, both ends are pink, so we join them together. Pink mucosa, nice to join after excising this bad segment. But in this child, the gut condition is not so good. It's quite dusky, it's congested, and therefore, to be on the safer side, we have done a chimney stoma, Bishop-Koop stoma. So proximal anastomosis, whatever goes down will go down. If there is too much of pressure distally, then things will vent out from the stoma. So this is a very nice way to make anastomosis in gut, which is not 100% correct. So this is again free gas, and this is the falciform ligament. It's also known as football sign or American baseball sign. So this is free gas on lateral decubitus cross table film. These days, we do not advocate doing erect films in newborns because making them erect push them under physiological stress. They're already sick neonates, and if you just have to take a X-ray in erect position, somebody will have to hold the child. It's quite distressful to the child. So what do we do? This is a better way of picking up free gas under the diaphragm. One is, of course, you take a supine film. Then the next film you take is lateral decubitus cross table film. So the child is lying on the left lateral side. So this is the left lateral. So right side is up, child is in lateral position. The X-ray plate is behind the back, and the X-ray comes from front. So what you're seeing here is, this is the right lobe of the liver. This is the abdominal wall. So there is gas between the abdominal wall and the right lobe of liver. And these loops of bowel, which are very, very clearly defined, they are actually floating because they're also gas filled. They have risen against the abdominal wall. But in the backdrop of free gas, their margins become very well defined because there is gas inside the bowel and there is gas outside the bowel. So the wall becomes very, very nicely outlined, as if somebody has marked them with a marker pen. Compare these loops here. There is no gas outside. There is only gas inside because all the gas which was lying outside has gone up because of gravity, because the child is in lateral position. And therefore, gas on both sides will lead to sharp demarcation of bowel wall, and it is known as Wriggler sign on plain X-ray. Same example, similar example. So these are the loops. There's a lot of gas. So many of the loops are so well defined, sharp margin. So this is Wriggler sign, lot of free gas. Same thing, lot of free gas. So what is the role of contrast enema then? Contrast enema identifies meconium disease and Hirschsprung disease so as to avoid surgery. So if you think that you can manage this child conservatively by the help of a dye study, then that's an indication to do the dye study because then you can avoid surgery. So it helps in decision making. And we know that gastrographin enema can be therapeutic for meconium disease. And it's a good way to initiate rectal irrigation in Hirschsprung's. So when you are in doubt, when you are not able to comment whether the given X-ray shows peripherally dilated colonic loops, there's a lot of distension, child is not that sick, or the child is born with distension, then you have to order a contrast enema with gastrographin. Do not order a barium enema. Barium sulfate is non-absorbable, is a contrast which, if it goes into the peritoneal cavity by way of perforation, then it will cause severe chemical reaction and the gut will become so adhered that it will not function. Also, gastrografin, if you use for contrast enema, it can be therapeutic in cases of meconium disease. If you use barium in that setting, it will be worse. It will worsen the child. Now, in Hirschsprung's disease, the child is otherwise well. I mean, this distension is there because in Hirschsprung's, what happens is colonic distension also occurs. And yet the child is comfortable. He can still be feeding very well. They are not born with distension at birth. They develop it later. They don't pass meconium. So what is the clinical way to suspect Hirschsprung? Child is not passing meconium, otherwise well. Abdomen is distended. Bilious vomiting also sets in very late, if at all it sets in. So no vomiting, distension, soft distension. You are able to feed, but then a point comes when the child doesn't tolerate and there is abdominal distension. You do a contrast enema and you pick up a transition zone. You prove that this is Hirschsprung's. And when you give contrast enema with gastrografin, it stimulates the gut and it leads to evacuation of meconium following contrast enema. And that becomes therapeutic as well. So for classical Hirschsprung disease, you can initiate the bowel irrigation process by doing a contrast enema, which will not only diagnose Hirschsprung's, but will also initiate the process of irrigation. And if it comes out to be a microcolon, then you know that this is meconium disease mostly. And then you wait. And if the child passes a cast of meconium followed by decompression of stools, then you know that the contrast enema has been therapeutic as well. So this X-ray I showed you. Another example of microcolon. Now, another differential diagnosis of microcolon. This child has microcolon all the way, right up to the ileum also. So this is redundant sigmoid, then goes up. This is the splenic flexure goes up, hepatic flexure goes down, ileocecal junction, and then refluxes into the ileum as well. So these are ileal loops. This is the sigmoid, but this is ileal. This is an ileal. So this is total colonic aganglionosis. So differential diagnosis of microcolon on a contrast study is first is meconium ileus, second is total colonic aganglionosis, and third is ileal atresia. Now for ileal atresia, one should not be needing contrast enema, but oftentimes it is difficult to make a clear-cut decision, and in that situation, it is wise to order a contrast enema with gastrografin. Now, why gastrografin? Why not urografin? Why not barium? Why not iohexol? Because if we want the contrast enema to be therapeutic, then we need to have a contrast which has hygroscopic property. Urografin is an ionic agent, iodine-based ionic agent, water-soluble, but hyperosmolar. So it draws water and it loosens up the meconium. And gastrografin also has a surface active agent called tween 80 that acts like soap. So it reduces the surface tension and allows disimpaction of sticky meconium from the mucosal surface of the gut. So it disimpacts. The hygroscopic properties allow the water to get into it, so it softens, and then it is stimulant to the rectum, and so the child passes it. So that is the reason why I use gastrografin, because of its surface active agent called tween 80, its hyperosmolar nature and ionic nature. Now, this is an example of somebody using barium for a contrast study. It perforated and it led to spread of the meconia, the barium all over the abdomen. So this X-ray was taken at the age of 9 years in this child because of persistent or recurrent intestinal obstruction. And you can see the barium still persists. So just to show you, barium should not be used. Please take it home. Barium should not be used. So we can leave it. Now we
So
come
there's a
to,
question, what is the commonest site of meconium impaction?
okay, it's the terminal ileum.
Okay. And how to differentiate chronic constipation from HD?
From Hirschsprung disease.
Yep.
Right. Well, in neonatal period, it is not pertinent, because in neonatal period, Hirschsprung disease will present with delayed passage of meconium or assisted passage of meconium. So if you stimulate just with a plain feeding tube and instill some saline, the child will decompress. That I'm talking about the classical Hirschsprung's disease, which is the rectosigmoid. So what happens in rectosigmoid Hirschsprung disease is only the rectum is at fault. So if you bypass rectum and introduce your feeding tube into the sigmoid, it's enough to cause stimulation and the child will decompress. So if the child starts decompressing on rectal stimulation, this is likely to be Hirschsprung's. Then you do a contrast enema and see the transition. I think I have a, yeah, so this is Hirschsprung disease. So when you do a contrast enema, you can see the rectum is collapsed, but there is transition zone like a funnel, and then the sigmoid is dilated. So if you pass a feeding tube up to here, then it will decompress. It will suddenly decompress, and child will decompress. If you do a rectal examination with explosion, the gas will come out. The child's distension will become less. He'll be feeling better, and you can feed. And these children actually can be sent home on breastfeeds or top feeds and daily rectal stimulation by the mother with the help of finger or with the help of a feeding tube, daily rectal wash, and the child will keep on decompressing, and then you operate at the age of 6 weeks to say 2 months, 3 months, and you can do a primary pull through without any need of colostomy.
Okay.
If the child has bypassed the neonatal period, it comes to childhood, and then it comes to differentiation between Hirschsprung and chronic constipation, which is a big topic in itself. There are several pointers. Good history taking examination, like smearing will never happen in Hirschsprung. Functional constipation, smearing is very common. Habits, straining, you do a rectal examination. If the rectum is filled with stool matter, it is functional constipation. If rectum is empty, it is Hirschsprung's. There's several pointers. And then you can do a contrast enema, and then you can do a rectal biopsy to make a final diagnosis. So the diagnosis of Hirschsprung should be proven by biopsy. So biopsy is the 100% diagnostic modality for Hirschsprung's disease. Does that answer your query?
Yes, sir. Thank you.
So this is malrotation. Now in malrotation, what happens is, this is very important because these children who come to you in the neonatal period with sudden collapse, sudden bilious vomiting, without any abdominal distension, you don't know what is happening. The Ryle's tube shows the bilious aspirate. The child has been well for first 4 to 5 days and then presents with bilious vomiting, failure to accept feeds, and the child becomes limp. You don't know what is happening. So that must be picked up very early, because malrotation with midgut volvulus is a fire brigade emergency. Malrotation can present in two forms in the neonatal period. Either it presents with midgut volvulus, which is a fire brigade emergency, or it presents as partial duodenal obstruction. Sometimes vomits, sometimes doesn't vomit. Child accepts feeds also. He is thriving well, but he is vomiting in between. He vomits bile. So again, in malrotation, what investigation? Remember, plain X-ray is non-specific for malrotation. You cannot diagnose or you cannot suspect malrotation on plain X-ray. Therefore, in such situation, upper GI series is diagnostic. Please do not read this as barium, read it as gastrography. This is a mistake here. So what do you see in the upper GI series? The DJ, duodenojejunal flexure, is not in the normal position, and there is dilated duodenum. On ultrasound, this ultrasound is important for diagnosis of malrotation. You see the axis of superior mesenteric artery to the superior mesenteric vein. Normally, SMV is to the right of SMA. If it reverses, then this is malrotation. No further questions. And sometimes you can appreciate a corkscrew appearance of the jejunum because it twists on itself. So this is a typical malrotation. It's very difficult to read. So I always take the help of the radiologist. So I can't tell you, look, this is a corkscrew appearance. Well, it is written here, but I can't take credit for that. So this is what happens. This is typical volvulus. This is not a neonatal operative, but this just to show. This is how the gut twists on itself, 2.5 turns, 2 loops going like this. This is cecum, appendix, and this is the proximal jejunum. So they're lying close together because the root of the mesentery is so short that it twists so that the cecum and the jejunum are lying opposite each other. So malrotation with midgut volvulus is the most dramatic presentation. Child is well for first 3 to 4 days, then passes milk stools, and then sudden onset bile vomiting, rapid deterioration with shock, and often there is no time for contrast study. And in this situation, you just quickly resuscitate with fluids and take the child up for surgery. And laparotomy may actually be a part of resuscitation. So don't worry if the child is typically presented like this. There is no need to do even a contrast studies. Just take the child to theater. Hirschsprung disease we have talked about. Now, a bit of, pardon me for a minute. Somebody is there at the bell, at the door. I'll just open it. ऊपर जाओ छत पे उसको देखो और देखो हमारे टंकी में पानी भर गया है या नहीं उसको पता उसे जाओ नीचे देखे बोलो जाके चेक करेंगे टंकी भर गई है कि नहीं sorry so do you still have time or do you want to take questions because it's almost...
So we have another 10 to 15 minutes. How much time will it take?
Just 5 minutes. Well, there
Sure,
is...
sir. Please go ahead.
So necrotizing enterocolitis, neonatal appendicitis, and isolated gut perforation, which is not related to NEC. These are other reasons for neonatal surgery on the bowel, but they cause functional obstruction, not mechanical. So far, we have discussed the mechanical causes of obstruction and their management. Now, if there is a functional obstruction, then what is important is chronology of symptoms. So obstructive symptoms appear in a well child if it is an atresia. But obstructive symptoms occurring in an already ill child, say for example NEC or any inflammatory condition of the bowel, the child will be sick, will be ill, and then the surgical reference will go if there is any obstruction. So the presentation in the beginning is different. Now this is typical, extensive necrotizing enterocolitis, extensive necrotizing enterocolitis. And this child will obviously be very, very sick. So decision for surgery needs to be taken very carefully. Although here we see that lot of extensive pneumatosis is there all over. Normally, the cases of necrotizing enterocolitis we see are limited to terminal ileum and like that. But here, as you see, it's an extensive necrotizing enterocolitis. Just a minute. उसको बोलो नीचे बटन बंद कर देगा मोटर का जो मैंने नहीं वो वाला नहीं अलग उसे पता है कौन सा इधर लेफ्ट हैंड साइड पे है So all of you are aware of this preoperative management of NEC. I don't have to tell anybody. Now I will not touch upon where is that indications of surgery in NEC. I think that's in a different presentation. But anyway, let me summarize. So varied causes can present with similar features, but you must remember the common causes. Duodenal atresia, ileal atresia, Hirschsprung disease, malrotation, meconium ileus, and NEC. Now, with NEC, the chronology of symptoms will be different because NEC will present as generalized, illness, abdominal distension, bilious aspirate, etc. And again, I'm reiterating, plain film is very, very important and it's often diagnostic. Contrast enema should be done if meconium ileus or Hirschsprung disease is suspected. And both of these conditions may not require immediate surgery, and contrast enema with gastrografin can be therapeutic. These are general neonatal points. Fluid resuscitation, of course. Remember, malrotation with volvulus is a dire emergency, and laparotomy may be a part of resuscitation. Don't insist on getting an upper GI contrast study just to complete your workup. But if the child is not resuscitable, please ask the surgeon to take the child up for emergency laparotomy. You may be able to save some gut. Fine. So I think I'll stop here. There was another presentation on NEC, when to decide for surgery, but I think there is no time for now. I think it is better if we discuss few points in the next 10 minutes or so.
Thank you, sir, for your wonderful presentation. I think most of the points are self-explanatory. There's a question by Dr. J.K. Kapoor. As told, duodenal atresia takes about 2 to 3 weeks to resolve. So to allay the anxiety on both the sides, can we give any suppository to relieve any distension? Sir, please stop sharing the screen.
Okay. So your question is, duodenal atresia will take time to resolve. So during
Yes,
that
sir.
time, is there any role of suppositories or rectal stimulation?
Yes.
A very good question, I must say. Now that will depend on what is happening to the plain X-ray. See, the reason for bowel not moving in duodenal atresia is twofold. One is the distal gut has never been used. That is one. And second, duodenum is very distended. So duodenal motility itself will take about 2 weeks to regain. So duodenum doesn't start sending fluid to the distal gut, and distal gut is not ready to receive it. So it's both ways. The pump is failed and arteries are clogged. Both ways. So if you look at the plain X-ray, say about 7 days later, and you see some gas going down, in that case, it is good to give suppository, stimulate the rectum. So start unclogging the arteries distally. The pump will take its own sweet time. There's nothing you can do to the duodenum, except in proximal jejunal atresias. Jejunum, we can still taper. There is a technique during surgery that you excise the most dilated portion and then start tapering the proximally dilated jejunum. So if you decrease the dilatation by tapering, it improves the function, and you can expect it to function a little better and a little faster. But decision to do suppository will depend on how much gas has traveled distally. It's a good idea too.
So can you please explain the procedure of gastrography?
Gastrographin enema or gastrographin upper GI study?
Actually, Dr. Manjusha, would you like to further ask the question?
I can answer
And-
both, but it's very important to know the correct way of doing contrast enema, because this is often done very wrongly. एक सेकंड, कैन यू जस्ट क्या किसकी? अच्छा, ओके, तो ऐसा करो, इनको तुम शाम तक तो हो, तो उसको बोलो फिर होंडा सिटी लेके जाएगा, मम्मी को लेकर आएगा। पेट्रोल है उसमें? ठीक ठीक, बस आप जाओ, मैडम को ले आओ। Sorry. So contrast enema. Now it depends on what you're suspecting. For example, if you're suspecting Hirschsprung's disease, then the contrast enema should be done in lateral position with an end opening tube, which is a feeding tube generally, non-lubricated. It should be advanced into the anal canal for about a centimeter only, not more than that. And never do it with a Foley catheter. Radiology departments do it with Foley catheter, which is completely wrong. Okay. And then you instill gastrographin under fluoroscopy guidance, just about 5 to 10 ml of contrast, and keep on looking at the rectal distension. The moment you see the transition zone, you stop. Your purpose is served, because the proximal colon you have visualized through a plain X-ray, the rectum you have visualized through the contrast, and you have seen the transition zone. So for Hirschsprung disease, that's over. For meconium disease, for meconium peritonitis, for total colonic aganglionosis, ileal atresia, as you will instill dye, it will keep on going up without showing any transition, like microcolon, typical microcolon. Okay. And then you keep on instilling till either you see the dye spilling into the ileum or you don't see it spilling into the ileum. If you have injected an entire colon is microcolon, then there is no point in further distending, because then it will cause perforation. And often when you are injecting, the rectum becomes distended and one gets carried away. Looks at rectum is distended, so proximal must be all right. But rectum is distended because you're injecting with force. So rectum should not become too distended when you're doing a contrast enema. If it does become distended, that means you are using more pressure or you're using more dye. And that can lead to a perforation. So beware. So the X-ray must be done by a resident, not radiology resident, not by radiology technician, but by a doctor from neonatal team, pediatric surgical team, because interpretation is very important. And when to stop is very important. Otherwise, they'll keep on taking 16, 17 films, which is unnecessary. So it takes 2 or 3 minutes. I sometimes go personally when I want the information that I want. And the radiologists are surprised, sir, अभी डाई स्टडी पूरी नहीं हुई है, अभी ये भी देखना है, ये भी देखना है. मैंने कहा मेरे कुछ नहीं देखना. My purpose is served. I made my decision. So it's very important. Now contrast upper GI. Upper GI, you have to tell the radiologist, look, I want you to tell me the exact position of DJ flexure, duodenojejunum. Once you have crossed the duodenojejunum, your dye study is over. Most of the time, you order an upper GI contrast study to exclude malrotation. Abnormal DJ location is diagnostic of malrotation. The normal position of DJ is in the transpyloric plane to the left of midline, at or above the transpyloric plane on the left-hand side. Anything less than that, even if it is in the midline, even if it is on the left side, but below the transpyloric plane, it is abnormal.
Right.
Position of cecum on contrast enema is not diagnostic of malrotation. Cecum can be wandering. So for malrotation, the only investigation of choice is contrast upper GI.
Anita Ho.
Right. So there is a question by Dr. Anupama. 2 months old baby, failure to thrive, recurrent vomiting, and feeds non-bilious. Looks hungry, sucking hands, breastfed, pylorus 3.4 mm. So how to investigate further?
So recurrent vomiting, one must look for intrinsic duodenal obstruction, intrinsic duodenal stenosis. Non-bilious or bilious does not matter too much, because duodenal obstruction can be there pre-ampullary also. Duodenal obstruction is a big topic. It can happen because of stenosis, can happen because of atresia, annular pancreas, a windsock abnormality, a duodenal diaphragm with a central hole in it. So there are several differentials for duodenal obstruction. This child will merit an upper GI contrast study with a view to pick up duodenal dilatation, duodenal abnormality, bands, malrotation, things like that. We have to exclude a upper duodenal obstruction.
Right. So will ultrasound also help? If there's
Ultrasound will help
pancreas?
in cases of malrotation by looking at the SMA, SMV axis. Not always helpful, because sometimes what happens is the twist is not complete. So SMA should be on the left-hand side, but if it comes anterior, then also it's a subtle abnormality. If it is to the right of SMV, then it becomes almost certain that this is malrotation. But it can change position. It can be subtle abnormality. So very experienced ultrasonologist can suggest, but then the diagnostic modality will be contrast upper GI. Because without malrotation, duodenal obstruction can happen. Intrinsic duodenal obstruction because of web, because of diaphragm with a central hole, stenosis, all these things can happen.
So what is the maximum time till we take meconium passage as normal?
Very subjective. Normally, if you leave the child alone, as I said, 95% will pass within the first 24 hours if they are term bound. Preterm bound, give another 24 hours. So 95% of preterm bound will pass in 48 hours. But then depending on maturity, if the child is extremely preterm, you will have to give more time. You know that preterm gut itself is immature. It doesn't move as fast as the normal gut. So prematurity with bowel problem is a very treacherous problem. Many a time, these children, you'll start some feeds, then you'll reach say 40 ml, and then the child will start vomiting, start developing distension, then will stop. Then you again start, you reach 60, then the again child will stop, and then you call the surgeon. In such situation, I look at the plain X-ray, look at the amount of gas, and I start gently stimulating the rectum with feeding tube, glycerin saline, and then they start passing. It takes time. So if there's nothing else happening, no signs of sepsis, no signs of NEC, then just wait and watch and keep stimulating and things will improve. So neonatal gut can give you a lot of problem.
Is spontaneous intestinal perforation?
Mhm. Spontaneous non-NEC related perforation can happen in cardiac babies. In cardiac babies where there is a right to left shunt, then what happens is even if small embolus gets into the arterial circulation and reaches one of the intestinal vessels, then it can block the supply to a particular segment. They generally lead to punched out perforation because they're ischemic perforations, perforations. The proximal and distal gut are all right. So that's usually in cardiac babies, in neonatal period. In older children, infective causes like typhoid perforation, they can be point perforations. And
There's a question
cecal perforations in newborn can happen because of Hirschsprung's disease.
So there's a question that is it normal for nil by mouth patients to pass meconium? It's a normal physiological phenomenon.
Very common. In patients with ileal atresia, duodenal atresia, jejunal atresia, they keep on passing meconium. Because see, in ileal atresia, what happens is, just a minute, please. Sorry. So, in normal babies, see, ileal atresia occurs because of a vascular accident. So during the first 6 months, 7 months, or 5 months, the child has been swallowing amniotic fluid. It has been going down and forming meconium. It's going down. So why do you have meconium aspiration syndrome? Why does the child pass meconium before birth? Because there is meconium in the distal gut. So if say ileal atresia has occurred at 6 months, so the distal bowel has still got meconium. They will keep passing. So passage of meconium does not rule out atresia. It is the passage of milk stools. If the child has been fed and the child has passed milk stools, yellow stools, then it rules out atresia because the food has traveled all the way down.
Right. Sir, if a term baby doesn't pass meconium by 24 hours, so how do we proceed further?
Is the child well otherwise? Then give another 24 hours. If no distension, give another 24 hours. If at 48 hours he is not passing, the child is otherwise well, abdomen starts becoming distended, पानी आ रहा था. So, sorry.
So by 48 hours also.
And then if the child starts becoming distended, you take a plain X-ray. And if there are a lot of bowel loops, distended bowel loops, but abdomen is soft, and plain X-ray, there is a calculated guess that the loops may be peripherally located, they may be colonic loops. Child is not having any bilious aspirate. Then you give a gentle stimulation to the rectum. Pass a feeding tube, pass in a saline and glycerin mixed together, say 5 ml each or 3 ml each, and pass it into the rectum. The child will pass meconium. Very often, the child will pass. Then you suspect that this could be Hirschsprung's. Then you don't rush for the dye study. Keep on giving rectal stimulation. Establish breastfeeding. If the child is established on breastfeeds or top feeds, child starts decompressing, there is no other problem, he comes on full feeds, you keep on doing rectal stimulation, and then discharge the child, and then call in the OPD, and then get a contrast enema to see the Hirschsprung's. The rectal, transition zone will not disappear because of the contrast enema or with repeated enemas. It's a myth. Many books will write, while you're doing a contrast enema for Hirschsprung disease, don't give a wash. Otherwise, the transition will disappear. It's a complete myth. It will never disappear. Your aim is to make the child accept feeds. Suspect it, but don't rush to make a diagnosis and treat.
Thank you, sir. Now that's all the question that we have. If there are any more questions, we'll get back to you in the faculty group.
No issues at all. Thank you so much.
How much feeding tube or what length can be passed?
Size 6 feeding tube, well lubricated, and pass it only for 3 to 4 centimeters, not more than that.
Okay, sir.
There,
Right.
the feeding tubes can cause rectal perforation. Rectal thermometers can cause rectal perforation. If at any point there is any resistance, stop. If you're unsure,
Thank you, sir.
call your consultant. Call me, call our resident. I tend to do
Right.
it myself actually because it's such an important thing. If you cause a rectal perforation by feeding tube, you can't accept it.
Thank you, sir, for your wonderful presentation and discussion. And we thank all the delegates for joining in the morning. And we'll be seeing you all again next Sunday. So till then, goodbye. Thank you, sir.
Thank you. Thank you, Dr. Jiten.
Dr. Bhandari, are you there? Mr. Sushil, please close the session. Thank you, sir.
Thank you.